Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the CRASH course are listed here. So let's start our case. In this case, we have a 4-year-old female with recurrent fevers for the past 1 year. Per mom, she has been having these episodes of fevers every 4 to 6 weeks for the past year. Motrin only minimally helps with the fevers. Fevers are usually up to 102 or 103 degrees Fahrenheit. During these episodes, she would complain of sore throat, fatigue, malaise, and generalized achiness over her entire body. Sometimes her eyes would be mildly red and may even be puffy at times, and occasionally she would have some abdominal pain. She denies any vomiting, diarrhea, or rash during these febrile episodes. She denied changes to the hands and feet and denied having red, cracked lips or any oral ulcers. She also denied any other URI findings. Patient has been seen in the clinic and ED several times for these febrile episodes and diagnosed with a viral illness each time. She has been treated for UTIs 3 times in the past year, all of which had negative cultures. She has had multiple throat cultures that have all been negative. Past medical history: she has had frequent ear infections and had ear tubes placed last year. She does have a history of constipation and had a barium enema that was done at 2 years of age, which was normal. Birth history was normal. Immunizations are up to date. She received her 4-year vaccines about 6 months ago. Family history: maternal grandmother has Crohn's disease and is on steroids. Several family members on the father's side of the family have had some quote-unquote nephritis. The cause of the nephritis is not known, but they ultimately went into renal failure. There is no hearing loss in these family members. No one else with this type of history of febrile episodes as a child. Social history: she lives with her parents and maternal grandmother. They have a pet bird. Mother is of Irish descent, and father is part Irish and Scottish. Physical exam reveals a temperature of 39.3 Celsius, a heart rate of 136, a respiratory rate of 18, blood pressure of 96/64, and height and weight are both within normal at the 50th percentile. In general, she's a 4-year-old child who is alert, awake, in no distress, and non-toxic in appearance. Skin has no rashes or lesions. HENT is essentially normal. The throat does have mild erythema, and the tonsils are 3+, with a small exudate seen on the left tonsil, but no other lesions in the mouth. Neck is supple. She does have bilateral anterior cervical nodes that measure about 1 to 2 centimeters. No other lymphadenopathy. Lungs are clear. Cardiac is normal. Abdomen is also normal. Extremities is normal with no joint swelling. Back exam: there's no CVA tenderness or spine tenderness, and neuro exam is normal as well. To summarize our problem list, we have a 4-year-old female coming in with recurrent fevers every 4 to 6 weeks for the past 1 year. These febrile episodes are associated with a sore throat, fatigue, malaise, and achiness. Occasionally she has some eye changes and abdominal pain. There is a family history of nephritis and Crohn's disease, and on exam she has some mild tonsillar exudate and lymphadenopathy. So in this case, we have a 4-year-old female coming in with recurrent fevers over the past 1 year. So we're going to go over a differential diagnosis of things that cause recurrent fevers, or maybe even some prolonged fevers. So let's go over the differential for this type of presentation. So the first category we're going to start with is going to be infection. So you have to think about different infectious causes. of recurrent fevers and or prolonged fevers. So if we think about different infections, you could break them up into kind of viral causes and maybe some bacterial causes. Some viruses that can give you this type of recurrent fevers or prolonged fevers. The three that come to mind that you always kind of think of together are EBV, CMV, and parvovirus. These very commonly can give you prolonged fevers, recurrent fevers. They can present very similarly with the fevers, with a rash, with sore throat, with myalgias, with exudate tonsillitis. So our patient had some of these findings during these febrile episodes. So these are things that you would have to consider as viral infectious causes of recurrent fevers. Other things that you have to think about are bacterial causes, but things that maybe you can kind of hide the infection, and maybe it's not as apparent or obvious on clinical presentation. So we have to think about places that maybe you can have a deeper type of bacterial infection that might not give you a lot of overt symptoms other than a fever. And in kids, there's various causes and presentations of different infections that can present to this way. So then one thing you have to think about is going to be different types of pneumonia. So it could be just a viral pneumonia, but it also could be a bacterial pneumonia, and it could be other type of infectious processes or pneumonias. You can think about TB and different fungal infections that can give you prolonged fevers or recurrent fevers when you have a pneumonia from some of these causes. So that's one bacterial infection that you have to, or location that you have to think about is a pneumonia, different causes of pneumonia. The other place that you have to think about is in the abdomen. So different abdominal processes can give you recurrent fevers or prolonged fevers because you could have a deeper infection and you might not have a lot of other symptoms. So different type of abscesses in the abdomen, so some sort of a perinephric abscess or a retroperitoneal abscess, the different type of abscess can do that as well. And then you can have like a pyelonephritis or a UTI or a perinephric abscess that can give you recurrent fevers or prolonged fevers with minimal other type of symptoms. So I think these are some of the things that you have to think about. Other things on the differential from infectious causes, bacterial causes that you can kind of hide an infection and just present with recurrent fevers include sinusitis. So sinusitis is always on the differential, and then osteomyelitis is also on the differential of a child coming in with recurrent fevers or prolonged fevers. So these are other areas that you can kind of hide an infection and just present with recurrent fevers or prolonged fevers. And the other one that you can think about is endocarditis as well. So subacute bacterial endocarditis, that many times can also present with these type of prolonged fevers and recurrent fevers. So I think these are some of the infectious causes that you have to think about as a child is presenting with recurrent fevers or prolonged type of fevers. And then you always worry about different rheumatologic type of causes, and then malignancies are the other categories that you have to think about. So if you think about malignancy, so if you think about oncology, then the causes of prolonged fevers or recurrent fevers in a 4-year-old child, a big one obviously is going to be ALL and different types of leukemia that can definitely present with recurrent fevers in a 4-year-old child. So you have to think about ALL and leukemia. Another one, especially at 4 years of age, is going to be neuroblastoma. Neuroblastoma can also present with fevers, can cause bone marrow involvement, and then other types of bone marrow suppression and neutropenias and infections and things. So that's something to consider. And then always another thing to consider is Langerhans-Stahl histiocytosis. Langerhans-Stahl histiocytosis can also present with recurrent fevers because, again, when you have bone marrow involvement, you can have suppression of the bone marrow You can have neutropenia and infections as a result of that. So all of these can potentially involve the bone marrow, and that's when you get the recurrent fevers. Especially if you have neutropenia and neutropenic fever and other infections, and then these malignancies themselves can many times present with fevers, recurrent fevers, prolonged fevers, and relapsing fevers. So that's another category that you have to think about then. And then, as I mentioned, rheumatologic, you have to think about, and then also autoimmune in that category as well. So those are other categories that you have to think about. So let's go through those possibilities as well. Okay, so rheumatologic and autoimmune is another category that we can think about as well. So let's put that up here. So there's different type of rheumatologic or autoimmune things that can present at 4 years of age. They can give you recurrent fevers or prolonged fevers. So some of the things to think about are going to include things like lupus, JIA, so juvenile idiopathic arthritis, so systemic juvenile arthritis can present with recurrent fevers, prolonged fevers, so that's something to consider. Now, in our patient, there is a family history of some sort of nephritis and kidney involvement, so maybe there's something autoimmune or lupus or something going on from that perspective, so that's something to consider. Another entity that we can consider under rheumatologic or autoimmune would be rheumatic fever. So she keeps coming in with these sore throats and exudates on her tonsils. So rheumatic fever is always a consideration where you can have the fevers, and then usually you have more joint involvement and arthralgias or osteoarthritis. Then obviously you can have the carditis, you can have the erythema marginatum and the rash of rheumatic fever. Then you can have the subacute nodules as well as part of the major criteria for rheumatic fever. So that's always a consideration as well. Another category or disease process in this category we always think about is Kawasaki disease. So anytime a child comes in with prolonged fevers or recurrent fevers of more than 5 days and other findings of rash or eye involvement or mucosal involvement or swelling of the hands and the feet, you think about Kawasaki disease. Now our patient again would have these febrile episodes and occasionally would have some redness of her eyes and things as well, so that's something to consider at the differential as well. And then also maybe we could put under here inflammatory bowel disease. That's always a consideration because you can have extraintestinal manifestations of inflammatory bowel disease where you have kind of arthritis, and you can have like fevers in addition to the abdominal pain. You can have uveitis and eye changes, so you can have other extraintestinal manifestations of inflammatory bowel disease. And there is a family history in our patient of Crohn's disease, so that is something that we should consider in this patient as well. So along with infection and oncology, and then rheumatologic and autoimmune, I think another big category is going to be immunodeficiency. So a child that comes in with recurrent fevers, then you think about some sort of immunodeficiency in this patient. We said it could be related to an underlying malignancy and bone marrow suppression from that, but there's other primary immunodeficiencies that can present with recurrent infections and then therefore the recurrent fevers. So given the nature of this child's fever curve, she basically has fevers every maybe 4 to 6 weeks. So there's an entity called cyclic neutropenia that I think you really have to consider as well. This type of patient where you get every 4 weeks or so you get neutropenia, and it kind of cycles, and then during those neutropenic episodes you might have different type of infections and these fevers related to the neutropenia. So she's having these kind of cyclic type of fevers, so I think cyclic neutropenia is something to consider on this patient as well. Other primary immunodeficiencies include common variable immunodeficiency. So that can present at this age as well, where you have low immunoglobulins, and as a result of it, you present with recurrent infections and recurrent fevers. So she can have common variable immunodeficiency. Another one is CGD, or chronic granulomatous disease. That many times will give you more skin infections and abscesses and cellulitis and skin abscesses. So maybe not as likely, but still something to consider would be the chronic granulomatous disease. And similar to this, where you have a lot of skin infections, there's another entity called hyper IgE syndrome. So hyper IgE syndrome can also present with lots of skin infections. So instead of hypo and low immunoglobulin and IgE, this is actually excess levels of IgE and hyper IgE syndrome, also known as Job syndrome. And this can give you a lot of skin infections and abscesses and boils and things like that. So that's something to consider as well. Then there's something called, an entity called Schwabman-Diamond syndrome. So let's see, Schwabman-Diamond syndrome, I believe it's SCHWACMAN, Schwabman-Diamond syndrome. I might have the spelling wrong on that, but it's called, there might be an H in here, maybe Schwabman-Diamond syndrome. So Schwabman-Diamond syndrome is basically neutropenia associated with pancreatic insufficiency. So Schwabman-Diamond syndrome is where you again have neutropenia, but you also have exocrine pancreatic insufficiency. So you can have diarrhea and fatty stools, and therefore you have poor weight gain and failure to thrive, in addition to the neutropenia and the infections. So that's an entity that's quite interesting, that can present with recurrent fevers, recurrent infections from the neutropenia, but also can present with diarrhea and fatty stools and failure to thrive from the pancreatic insufficiency that's associated with it. And then other immunodeficiencies, you always have to think about HIV. So it could be congenital acquired, congenitally acquired, or it could be acquired in other ways as well. So HIV as a secondary immunodeficiency is something to consider as well. So I think these are some of the things you have to consider at this point on this type of a child presenting with recurrent episodes of fever. And then there's some other categories that you have to think about as well. So these other categories that you're going to think about now are related to periodic fever syndromes. So let's talk about some of those. So different periodic fever syndromes, which this girl could have because she's having different kind of episodes of fevers periodically. So I think there's a few entities that you have to think about here. One of the most common causes of periodic fever syndromes, one of the entities that's in this category, includes something called PFAPA, PFAPA. So the P stands for, the PF, stands for periodic fever. A is aphthous stomatitis. This P is for pharyngitis, and this A is for adenitis or cervical adenitis. So it's periodic fever, aphthous stomatitis, pharyngitis, cervical adenitis. So PFAPA is an entity that can give you periodic fevers. So that's something to consider on this child coming in with these cyclic fevers or periodic fevers, is the entity of PFAPA. And then there's other things. There's other processes. So one is called TRAPS, as another type of periodic fever syndrome. So TRAPS stands for TNF receptor associated periodic syndrome. So TNF receptor associated periodic syndrome is what TRAPS stand for, and it's similar to PFAPA in the sense that it presents with these periodic fevers and then other kind of myalgias and sore throats and things. The previous name, an older name for this, was called Hibernian fever. Hibernian fever was an older name, and now that we know the mechanism of it, and it's related to the TNF receptor, now it's called TRAPS, but it was called Hibernian fever. And if you remember your old and ancient geography, Hibernia is actually the area of Europe that now is Scotland and Ireland. So people of Scottish and Irish descent from Hibernia, from that area, would present these type of recurrent fever episodes, and it was called Hibernian fever, and now again it's called TRAPS. Now our patient, the parents actually were from Scotland and Ireland and had some ancestry related to that, so that was something that was being considered in this patient as well, along with the PFAPA and TRAPS as different types of periodic fever syndromes. Then the other couple that you have to think about is familial Mediterranean fever. So familial Mediterranean fever. So their ancestry is near the Mediterranean area, Mediterranean Sea, with Ireland and Scotland and things, but not not as close as you might think, obviously, to the Mediterranean Sea. But familial Mediterranean fever can present with lots of different fevers, a lot of other findings, and different types of serositis and polyserositis. So a lot of abdominal pain, a lot of joint pain. So it can present quite dramatically. And then one last entity in this periodic fever syndrome category is called hyper IgD syndrome. So we had mentioned hyper IgE, but this is actually hyper IgD syndrome. And that can also present with recurrent fevers and periodic fevers. So these are some of the things that you have to consider in our patient that is coming in with these recurrent episodes of fevers. So this was kind of our differential diagnosis on our patient, the 4-year-old girl coming in with 1-year history of recurrent fevers associated with occasional abdominal pain and eye redness, but also some kind of fatigue and myalgias and the cyclic type of fevers and recurrent type of fevers. So again, our differential diagnosis includes infectious causes, some of the viral causes, some of the bacterial things that you might think about, and then different malignancies, then rheumatologic or autoimmune causes of recurrent fevers, and then different immunodeficiencies, and then the periodic fever syndrome. So this was our working differential on this patient, and then we approached this patient systematically and methodically to help start to rule in and rule out some of these different disease processes. So let's go over and think about what type of workup we should be doing and how to rule in and rule out some of these entities then. So we started with a basic workup on this patient. And we did some labs, did a CBC, a CMP. We also did some inflammatory markers, a SED rate and a CRP. Checked for a blood culture, got urine culture, did some viral titers like EBV titers, and we also checked her immunoglobulin. So kind of approaching the patient and looking at her kind of holistically and seeing what we might find. And as we did the workup, the CBC was essentially normal. Her CMP was also normal. Her inflammatory markers were quite high. Her SED rate was 84, which is quite high. Anything above 20 is abnormal, and once you get above 60, that's quite high. So she definitely had something going on, inflammatory or infectious going on. And her C-reactive protein was also elevated at 4.7, which the normal being less than 1 in our lab. So again, consistent with some sort of inflammatory infectious type of process. Her UA was normal, her urine culture, blood culture came back negative, her EBV titers were negative, and her immunoglobulins also came back normal. So that helps us kind of rule out some of the things that we were thinking about at this point. But nothing stood out at this point of our workup. So we continued to manage her as an outpatient, and she defervesced and was afebrile, and about 4 weeks later she came back in to the clinic with another fever episode. So we kind of repeated the CBC, SED rate, and CRP just to see what was happening, and then we added some more labs. We did a little bit of a rheumatologic workup. We did a little bit of a workup for malignancies by checking a uric acid and LDH level. We did some strep type of studies, ASO titers, anti-DNase B levels, just kind of look into some of the other things on our differential. Then we did some imaging as well, we did a chest x-ray, looking for pneumonias or other type of infectious processes. We did an abdominal ultrasound to make sure she didn't have like a neuroblastoma or some sort of mass, and then did an upper GI with small bowel follow-through to make sure she didn't have anything like Crohn's disease or IBD that we could pick up. And then we also were an echo of her heart to make sure she didn't have endocarditis. And essentially her CBC, SED rate, and CRP were about the same, so still consistent with some sort of inflammatory respiratory infectious type of process. And the rest of her studies really came back negative. Her LDH, uric acid were normal. We did more of an immune workup, checked her B cell count and her T cell count, her IgE levels, and those were all normal as well. Her strep titers were negative, and her imaging was also normal or negative as well. So at this point, we still didn't have an answer, but we were at least starting to rule out some of the entities that we were thinking about. Her ANA did come back mildly positive at a level of 1 to 1280, which is mildly positive. So it didn't jump out at us, but caught our attention, but didn't really jump out at us. But because of that, we did do a little bit more of a workup from a rheumatologic perspective and check for anti-double-stranded DNA levels to look for lupus. We sent C3 and C4 levels. We sent antibodies to SSA and SSB, again looking for lupus, Smith antibody, RNP antibody. So we did a little workup from a rheumatologic autoimmune perspective, and that also came back negative as well. So now we were left with considering periodic fever syndromes. We were thinking about cyclic neutropenia, but every time we did a CBC, her absolute neutrophil count was actually normal. So we were now thinking more periodic fever syndromes. And our initial thought was possibly TRAPS, given the genetic background and ethnic background of her family. And there's genetic testing that we could do for that. So we sent off genetic testing for that. And that actually came back negative. And then other things, again, we're thinking about familial Mediterranean fever and hyper IgD syndrome. Not as common, so we didn't look into those immediately. But we looked into TRAPS, and then we were thinking about PFAPA as a possible cause as well. And like I said, we did the genetic testing for TRAPS, and that came back negative. And actually, we ended up ruling out these other entities of familial Mediterranean fever and hyper IgD syndrome, which again are genetic testing, to help us rule those out and make a presumptive diagnosis of PFAPA. So once we had ruled out genetically all of these other periodic fever syndromes, and we had done a quite extensive workup, we ended up making the diagnosis of PFAPA. And again, we said PFAPA stands for periodic fever, aphthous stomatitis, pharyngitis, adenitis, and she presented with a lot of these symptoms when she would come in with the fever, the sore throat, and the cervical adenitis. She never really had mouth sores, but that's actually one of the less common things that you see in this entity then. So we made a presumptive diagnosis of PFAPA based on her clinical presentation, ruling out these other causes. And then the treatment of PFAPA can sometimes be treated with steroids. So during an acute episode, febrile episode, you can give steroids, and that can really help reduce the course of the fever and help them return to baseline very quickly. But it doesn't prevent the recurrence of the next episode of a febrile illness. So it can help for an acute episode, but it doesn't prevent it from happening in the future. So different therapies that have been studied and suggested. One includes cimetidine, so having the patient on cimetidine regularly on a daily basis can actually help reduce recurrent episodes of these fevers. And then studies have shown tonsillectomy with or without adenoidectomy can help reduce the fevers and the reoccurrence of the flare-ups. And our patient ended up having a tonsillectomy and adenoidectomy, and actually did great after that, and never really had any fever episodes following that surgical procedure. So she basically was treated with surgical intervention by having her tonsils and adenoids taken out, and that basically helped cure her PFAPA syndromes. Now usually PFAPA will resolve over time, and it usually starts around 3-4 years of age, and then usually by around 7 or 8 years of age, the episodes basically resolve on their own without any type of treatment. But in the meantime, it could be very difficult to have recurrent episodes of fevers and symptoms and things. So many times the cimetidine or tonsillectomy, adenoidectomy might be done if there's a lot of recurrence and relapsing of the fevers then. But usually you just kind of outgrow it by around 7 or 8 years of age. But for her, we didn't wait that long, and we had her tonsils and adenoids removed, and she did great after that. I did not have any symptoms after that then. So basically then this patient, she ended up having PFAPA as the cause of her of her recurrent fevers, but it was a very broad differential diagnosis. It had to be a very methodical approach to rule in and rule out some of these things, and we ruled these out over several weeks, and then ultimately made the diagnosis of PFAPA, which unfortunately there's no genetic testing or absolute test that you can do to make the diagnosis. Yeah, it's a diagnosis of exclusion, so you have to rule out a lot of other entities and genetic testing to check for the other entities, which we did, and then you ultimately make the diagnosis of PFAPA and treat accordingly. So this is a case of a child coming in with recurrent fevers, every 4 to 6 weeks, with sore throat, with cervical adenitis, and a very broad differential. So you can use this case to read more about other things on this differential. I'm not going to go over each one of these as part of our CRASH cases. We just kind of go through the differential and the approach to these patients, and we don't talk about each entity. So now you can use this case though to read about some of these other entities, to read about TRAPS and familial Mediterranean fever, or other things like the board love to ask about Schwabman diamond syndrome, sickly neutropenia, CVID, chronic granulomatous disease. So you might want to use this case to be able to read about some of these entities. So hopefully this gives you a nice overview of recurrent fevers and the differential diagnosis as part of our CRASH case for this particular patient. And we hope to see you for future CRASH cases as well.